Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. All right. Well, I am ecstatic to be here today with a really special guest, Dr. Beachgem, as most of us know her on all the social media platforms. I kind of stumbled on you on social media one day and started following you, really because you're like the PEM doc that lives next door, you know, that we all want to have in our pocket, right? Like just down to earth and approachable and giving us all great information. And I went to work one day and I heard all the girls talking about you. And I was like, you know this person too? So it's like there's such a thing in our ER. And then they were like, hey, she knows Shelly. Like we have this mutual contact. And I was like, no way. So super small world. Yep. Thank you so much for being here with me today.
Well, thank you for having me. This is awesome.
Yeah. And today's my birthday. So
Happy
this is
birthday.
Like the best birthday gift a girl could ask for. One of the things I appreciate about what you do is just how you talk about things and have talked to people. I think, you know, for me, medicine is of course half what we know, but it's the other half is really how we relate to people, right? Like connecting with people and helping them to kind of understand what's going on with their kids. So I love that about you. The reason why I follow you is because scripting, you know, I think it's just awesome to hear all the different things you say.
Thank you. And the funny thing is I don't do any scripting before the video. So it's ironic that that's the word. That's the word.
Yeah. But the stuff we learn, you know, in practice, right? Yeah. You know, we all fail some, I think, especially when we're new.
Yeah.
But we learn what works and what communicates things to parents. So I appreciate that. You have lots of experience, so tons to learn from you. I appreciate that.
Yeah. Thank
you. How has, I was going to ask you today, like how this sort of TikTok social media fame has changed your life, but I actually saw you posted about it, I think yesterday. So I'll spare you that question, but has it changed like your personal life at all?
Not really, I don't think. I think the one thing that maybe changed a little bit is I tend to get recognized when we go out. So, you know, we went to the pier with my kids, a couple weeks ago. And I was like, all right, you know, in the car, like what's the number? How many times is somebody going to come up and say something? And then we have to like look at the factors and stuff. So, you know, my kids definitely are aware of it. But, you know, realistically, like my life is pretty much the same as it was. That's why it's very surreal that this has happened, this whole like social media thing. Because it's just, we're still doing our thing. And I just happen to talk to my phone sometimes. And then there's all this other stuff happening. People come up and say hello and, you know, podcasts and partnerships. But everything feels very much the same.
Yeah. Still a real human.
Yeah.
Does it change work at all? Like, do patients recognize you?
Oh, yeah. I definitely get recognized a lot by patients. And I think that has changed like maybe the pressure a little bit because they have this idea that I'm Dr. House and I'm the most, you know, caring and compassionate person. And then I'm like, okay, I have to care and be compassionate. And, you know, some of the cases are more challenging. You know, sometimes it's patients that are not vaccinated. And I was like, oh, you follow me. Okay, cool. We've talked a lot about vaccines. I'm a little surprised that you follow me. And, you know, I try to be compassionate and empathetic with all of my patients, but it puts a little bit of extra pressure when they, you know who I am and have those expectations going into, you know, the moment I walk into the room.
Sure. I've actually been working on that. My scripting for parents that are unvaccinated, you know, trying to get out of my mental models and get in theirs and try to, you know, find some common ground and talk to them about how to protect their kids. So, you know, definitely an art.
It really is. And online, I'm very pro-vaccine. In the hospital, it's like judgment-free zone. Like, I feel like, and I feel like that's a piece of growth that I have had is it doesn't matter what decisions they've made up until this point. Like, we are partnering together to make decisions that are in the best interest for this patient. And I've had some patients that don't want to tell me whether they're vaccinated or not. And I was like, I'm not here to judge you about it. It's just purely to discuss risk because not having a vaccine could put you more at risk for these certain things. And we may need to look more specifically at them. Not judgment, just need to know for risk. And that really has helped me with like the burnout part of it. is just like, I'm not here to judge. I'm just here to partner with you and like, let's address it.
Yeah. And not that we're here to talk about vaccines, but sometimes when I educate them why I'm like looking for certain ones, they're like, oh, maybe we should talk to our pediatrician about that. And I'm like, yeah, go have a conversation. So it's opened up some good doors for communication. I think it's good.
Agree. Like 100%. And I know that the pediatricians have talked to them about the risks of sepsis and meningitis and epiglottitis and things like that. But, bringing up an unvaccinated kiddo with croup, we may need to consider an x-ray because epiglottitis is on the table for you where it wouldn't necessarily be, for another kid that has croup that's fully vaccinated.
Yeah. Have you seen a case?
I have.
I have. See, I had never have. And it scares me to death because am I going to, are we going to find it? Obviously we should find it, but.
Yeah. We called anesthesia because we needed to put a breathing tube in the patient. And I was in fellowship and it was early in fellowship and they let me try the intubation and, there was just so much swelling that he's like, you should have used this one. And like, look right here. I was like, oh man, that was pretty cool. He's really skilled at that. But, it's one of those things. I'm really glad that I was in fellowship getting that education. And I feel like I could do it now, but still love having anesthesia backup.
Amen. Yes. Thank you for working at a big facility. I have anesthesia at my fingertips too.
It's amazing.
All right. So just kind of a fun question. What's your favorite thing to manage in a shift?
I think everybody's favorite thing is always like a nursemaid's. I love a good nursemaid's. Oh man. The thing in emergency medicine is that we don't always cure people. We're maybe diagnosing them, maybe starting some antibiotics, but we usually don't get to cure them completely within that visit. Mm-hmm. And a nursemaid's, they go from injured to cured in 5 minutes and then they get a popsicle. Like, it is amazing, and you get that satisfaction and that pop. It just feels so good. And parents think you're a magician because they really thought the arm was broken. So it's just something really satisfying to me about a nursemaid's elbow. It's amazing.
Yeah, it's a classic for sure. Okay, awesome. All right. Well, small world. I think we talked a little bit about this. We're here today because we have a mutual contact, Shelly Murphy. She is one of my colleagues that I love and respect, and she did our first podcast on bronchiolitis together. So nice. Shout out to Shelly for making this happen today. So we're here to kind of talk about pneumonia. What I learned when I transitioned from taking care of adults in the emergency department and children was that, we don't irradiate everybody that walks through the door. Now, we all kind of know that pneumonia is a clinical diagnosis. You don't have to have a chest x-ray to diagnose pneumonia, despite what some parents think. But in the ER, of course, we use a lot of radiation because we can and we do. So I really just want to kind of pick your brain when you're assessing a kid that comes into the ER with respiratory symptoms. For kids specifically, what really kind of makes you concerned for pneumonia in a child?
I think the most common thing that I'm, consistent factor is going to be the duration of illness, usually for kids. You almost never see a pneumonia on day 1 or day 2 of illness, unless they've been sick leading up to it. A lot of times it's, kind of the longer the symptoms are going on, you're looking at, 5, 6, 7 days, continued fevers, maybe worsening cough. And then I think it's also really important just to look at your vital signs. Looking at a pulse ox that's, not 97, 98, 99%, maybe it's like 94, 95, maybe there's something going on here. They don't have wheezing, it's not asthma. And then the respiratory rate, and also just if their heart rate is elevated, like always a red flag that we need to see what's going on here. And obviously we need to know age specifics for the heart rate, but, usually there is something that's going to clue you in that this kiddo has pneumonia and it's not just normally your normal cough and things like that. So, duration of illness, once you're getting more and more days of illness, you have to be more and more suspicious that there's an underlying or secondary infection.
Mm-hmm. What about anything the parent might describe seeing at home that would kind of make you concerned?
I think respiratory distress or difficulty breathing is probably one of the bigger red flags. So you have the sucking in of the skin between the ribs, those retractions, using those extra belly muscles to breathe, or fast breathing. Those are the things that I tell parents really to watch for. And kids that have pneumonia tend to be maybe even a little sicker appearing than you would expect for a common cold. Maybe they're laying around a little bit more than they would. But flu kids can also look really sick without having pneumonia. So that's a little bit difficult. So the work of breathing is going to be really the telltale sign at home, in addition to, it's been 5 days of fever, 6 days, 7 days of fever now.
Yeah. What's your typical workup for a kid like this look like?
So I think, always starting with your vital signs and physical exam, in addition to your history. So go in, your primary assessment's a huge, is the kid running around the room, you're having a hard time catching them to do your exam. That's a kid a lower suspicion, but higher suspicion, kid that's, quiet, a kid that's, sitting still. A lot of times they're still pouring snot out of their nose, they're breathing a little faster, and then you're, listening for the things like the crackles, you're looking for the retractions on exam. And then kind of putting the whole picture together, is this a kid that we need a chest x-ray on, or is this a kid that we can diagnose clinically? In the ER, we have the resources. We usually do just grab the chest x-ray, go ahead and get it and make sure that, we don't see something. And if we do see something, then we can manage it.
Yeah. Do you routinely get labs?
I think it depends on the kiddo, and is the lab going to change the management? I think is, the ER slogan. Is this a kiddo that I'm worried maybe, developing some dehydration? Are they getting kind of septic-ish? Do they have a bacteremia in addition to the pneumonia? And again, those kids don't look well. Sick kids look sick. And so again, if you have the kid that's been, maybe he's had a fever for 7 to 10 days, you get a chest x-ray, it shows a pneumonia, but they're running around the room and you're having a hard time catching them. Yeah, probably less likely to get labs and maybe just start some oral antibiotics, make sure they have close follow-up with their pediatrician, would be more likely. But again, I think you have to go on that clinical gestalt, and that comes a little bit with time.
Yeah, I agree. I generally start with the chest x-ray if they look good, because I think they're going to go home. Yeah. But if they're looking like they're going to stay, I'm probably going to get some labs. Yeah. Do you guys ever trend procals on these kids?
No. We haven't seen good evidence of procals in kids outside of the newborn period. So we, a couple years ago, we got procal. We didn't have procal for a long time in our lab. It was a send out or something. So we finally got procals a couple years ago, and we used them with our neonates, and they recently restricted, so you can't use them outside of a certain age range. I think it's like 3 or 4 months, that you cannot even order a procal on a patient. So we don't trend procals. We don't look. If we can get blood gases that have like the all analytics, you can get a lactate on that. So that would be what we would be looking for if we were really concerned about sepsis. We wanted to resuscitate that kiddo.
Yeah. Our adult side cannot use procals. You can use them in the ICU, and we can use them in children's. So yeah, we're kind of limited too, but in children's, we get to use them now. Okay. Any special considerations for pneumonia? I know, something that I didn't know about before working in children's was this kind of post-flu situation. Can we talk about what that would look like?
Yeah. So the kiddos that get flu and end up with pneumonia have a tendency to be quite a bit sicker. And they can be, the pneumonia that you have to consider with flu is MRSA, methicillin-resistant staph aureus. And so we do generally use different antibiotics than we would typically use. Your go-to is going to be amoxicillin or Augmentin for a community-acquired pneumonia usually. But you also have to consider MRSA coverage, and you want to look at your local antibiogram, whether it's, Clinda or something like that, for coverage of your flu pneumonia.
Is that usually what you guys do?
Yeah, our antibiogram's still looking okay right now for MRSA and Clinda, but again, low threshold, want a quick follow-up if they're not getting admitted, and if they're not improving, then you'd want to consider switching coverage.
Yeah, we tend to admit those kids and do like a vanc or a vancomycin coverage, so I'm sure it depends on your area.
Yeah, and we, for some reason, we've had so many kiddos that have multiple positives on we've done a lot more respiratory pathogen panels recently because of the Mycoplasma situation. And so a lot of them, they've got adeno and flu. So now, this kid's probably going to be sick for like 7 to 10 days pretty good. So if their cough's getting worse than 7 days, you get a chest x-ray, you still got to cover for the MRSA, but, and they look good still. So, it's been a little bit more complicated, I feel like, because we're finding, multiple viruses. We're not just getting a positive a flu test on them, rapid test and triage. It's, we're having to deal with multiple viruses. They're sick longer. So it's been a more complicated season, I feel like.
For sure. In this population, who are you admitting to the hospital versus who are we sending home?
Yeah. So, a kiddo, if they're getting admitted to the hospital, they should be getting admitted for something, right? So they're hypoxic. So they're needing oxygen supplementation. They're tachypnic, they're in distress, they need some sort of respiratory support in that way. Maybe it's high flow or BiPAP or something like that. Kiddos that are getting dehydrated, not tolerating oral intake, for some reason needing IV antibiotics, whatever that is, if they're failure of outpatient management or something else like that. So I think those are some of the bigger considerations. If you have a chest x-ray that's bad enough, I think it's reasonable to admit for observation. But realistically, like, we should be doing something. There should be an intervention for the kiddos needing to be hospitalized. We get a lot of calls from other hospitals. There's a kiddo, doesn't need any oxygen support, satting well, vitals are perfect, tolerating oral intake at home, and they want to transfer the kiddo for admission. It sounds like they're okay for outpatient management. I'm always happy to take a look if you want me to, but I'm not going to admit a kid that is looking beautiful, tolerating intake, not in any distress, doesn't need support. Usually there has to be something that you're admitting for, would be kind of my general rule.
Yeah. If you're sending a kid home, what do you tell them with regard to follow-up?
For my respiratory kids, I usually recommend closer follow-up. And maybe that's a reason that you admit, is because they don't have follow-up and you want a good evaluation in 24 hours or so. Depending on what they're looking like and, what day of the week it is, usually a 1 to 2 day follow-up for respiratory support, and then really strict return criteria. Difficulty breathing, dehydration, altered mental status. This is what retractions look like. A respiratory rate over this amount that's persistent, I'd want to see them back.
Yeah. And outside of the crazy stuff we've seen in pneumonia this year, what would you have said last year would be your go-to med for treating a kid outpatient?
I usually bump up from amoxicillin to Augmentin. I think I'm a little conservative like that, just to get some extra coverage. But, in a kiddo that hasn't been on antibiotics recently, I think amoxicillin is a reasonable choice to start with as well. Yeah. Obviously TID for pneumonia.
Yeah. High dose TID. Yeah. Okay. Well, let's kind of get into this crazy year. It's, at least 6 months here that we've seen this kind of incredible prevalence of pneumonias.
Yeah.
What have you guys been seeing in Florida?
I think it actually for us started closer to maybe March or April of this year. And we were just seeing tons and tons of pneumonia. And it looked more like just regular bacterial pneumonia. Yeah. We did RPPs on them. But for the whole spring, we were seeing just a wild number of really bad pneumonias. And then kind of right after that, maybe a month or two later, it was just everyone had mycoplasma. And all summer long, even into the fall, everyone had mycoplasma. And some of them had pretty wild pneumonias, things that we wouldn't typically see. We read in the book, it's bilateral. And they weren't. They were very low bar,
yeah.
Isolated. It was very strange. We did have some kiddos that were quite ill. And some of them tested negative on the nose swab, but then were positive on a bronch. When we bronched them for what's going on, we can't figure out why they're not getting better. And they were positive for mycoplasma. So we did a lot more empiric coverage using azithro, throughout the summer, especially for kids that needed to be admitted for pneumonia.
Yeah, it's interesting you said that. We read probably a few months ago that if you do just this anterior nasal swab, you're going to miss it. Yeah. So a lot of us were just double covering a lot of these kids that were going home just to be careful. Do you guys switch to more of a double coverage approach?
Yeah, a lot of the kiddos, especially the school age ones, were considering double coverage. And especially maybe even the kiddos that are, they've been on treatment for maybe 5 days, 6 days. They don't seem to be getting better. Making sure that they're double covered. Because obviously a lot of this, things that we're seeing in the hospital, they're not necessarily finding out. The outpatient is a little bit delayed because they're not able to get RPPs on everyone, respiratory pathogen panels on as many people. And so I think we were seeing it and adding coverage, and then they started realizing as an outpatient, I think we're seeing a lot more of this than we're realizing. And so they started double covering more as well.
Yeah. That's something that in the adult world is done all the time. So we were doing that constantly. And so it was kind of funny to full circle for me coming around doing this again. If you're out there and not familiar with what mycoplasma normally looks like in kids, historically more of our school age kids, kind of that butterfly patchy sort of reticular pattern on a chest x-ray. Is that kind of what Yeah. And we've seen it on babies, 2-month-olds, and we're all just what? This is so bizarre.
Yeah. It was, and for a while, our ID people no, we don't really see it in kiddos younger. And then we were bet. And this, the spring, summer, and fall, the season, we were just anybody, everybody's getting it. It's tons of babies, toddlers, infants, all the way up through our, school age and teenagers with the mycoplasma.
Yeah, and hypoxic. Like we admitted a lot of these kids. So interesting that you're seeing like almost the same pattern. I was piqued when I saw you post about this because I was like, dang, that's like the same thing we're seeing.
Yeah.
I read some news articles about it. It seems like it's been a lot of the country, but not everywhere. Like Pennsylvania, North kind of excluded. What have you heard?
Yeah. So they posted about, because obviously I'm on the social media, like there was the white lung in China, concern for pneumonia that was December of 23. And so then they started seeing it in the Ohio and Pennsylvania area. And then I think we started seeing it. And then I think we were seeing it a little bit before the rest of the country. And, our mycoplasma numbers, I really think have dropped off over the last like 2 or 3 months. Like, I don't think we're seeing near as much as we have in the past.
Yeah. I don't find that everybody's popping positive like they were for a while. Yeah. I had a couple on my last shift, but I was like, oh, okay. All right. Yeah. Do you feel like this season has changed your practice forever, or do you feel like this is kind of like isolated?
I think I have the benefit of working a lot and seeing what the respiratory pathogen panels look like. And so when we're not seeing much, I think that we can kind of back off that practice a little bit and not add extra antibiotics when we don't need extra antibiotics. And obviously, like we always have the benefit of going back and saying, listen, if you're not getting better, then we have to consider further, other things. So make sure that we're following up. And so I think it's nice to have that kind of background surveillance of like, we're seeing a lot of this right now. Maybe we'll consider this, or we're not seeing a lot. So I think we can hold on to double coverage kind of thing.
Yeah. When I didn't work at Children's, I thought my friends at Children's were just like the smartest clinicians I'd ever met. Like, I'm like, how do they know? Like, they know every season and every trend, and they know exactly what this person has. They don't even go in the room. And after I switched over, I was like, oh, okay, we're cheating. Like, we're watching this in real time.
Yeah. The residents think I'm like so smart sometimes because I'll be like, no, like this, it's this, and this. And they'll be like, oh, okay. And then we go in and they'll be like, boom, boom, boom. I'm not that smart. I've just done this forever. It's pattern recognition. Like, we just get it.
Yeah. Yeah. It's awesome. I love working with kids. I think it's the greatest thing ever.
It is.
All right. Have you guys seen any pertussis?
Yeah. Yeah. We're starting to see some pertussis. I heard a lot. There were a lot of other people that were like, yeah, we're starting to see it. We're starting to see it. I was like, we're not quite seeing it here yet. I'm sure it's out there, but we've started to see it over the last maybe 6 weeks. We're starting to see more cases of it.
Are your kids vaccinated or unvaccinated?
My actual children? Like,
no.
Like my hyper vaccinated.
You're the pertussis cases.
Mostly unvaccinated, though we have seen a couple that have been vaccinated.
Yeah, I've had 2 that were vaccinated, and I was like, oh, okay, interesting.
The ones that I've seen that were vaccinated were at the end of they probably didn't have much immune response left. It had been more than like a couple of years since they had their last pertussis vaccine.
Oh, I see. Getting ready for their next booster.
So they were kind of like due for their next one. It had been a couple years, but I think more than 5 years for both of the ones that I saw that were vaccinated.
Yeah. I think I saw a 4-monther that had just had the 2-month. And then a little kind of older kid kind of in that between phase like you're talking about too. Okay. Do you guys have a test for mycoplasma, by the way? I meant to ask you, like a singular test, or do you have to RVP them?
RVP.
RVP.
Yeah.
All right.
So we've been using a lot. We've been doing a lot of RVPs.
Yeah, we were running out of them last week because we've been using so many of them. It's just, they just take so long. It makes the visit lengthy for us.
How long do they take for you?
At least an hour, if not 2.
Yeah.
Yeah. And a GI path is like 3 or 4 hours.
Yeah. I think ours is closer to like 5, 6, but our RPPs are, 1 to 2 hours.
Yeah. Yeah. Crazy. And around Christmas time when we ran flu and COVID on everybody, it took hours to get a flu and like a singular flu or COVID test. And it was actually faster to get an RVP because we weren't running as many of them because we were seeing all the flu. So anyway, this is the days in the hospital.
Yeah.
All right. Anything you want to add?
No, not really.
Okay. Well, I can't thank you enough for doing this. It's been fun.
Yeah, that's cool.
We would love to have you visit us here in Chattanooga.
That sounds fun.
Yeah. Have you been to Chattanooga before?
Oh, no. I don't think I have been, actually.
Yeah. It's a really cool, super like family friendly town. And you've got some friends here and a whole bunch of fans. So this is your official invitation. We'd love to have you come visit us.
Very cool. I'll schedule a trip up.
All right. All right. Thank you so much for being here. Dr. Beachgem.
Hey, PemChat family. Thank you so much for joining me today for this fun discussion with Dr. Beachgem. It was awesome to have her on the show. Exciting to get to meet her. Please join me next month when I'll be joined by the Ortho Bros, Dr. Chuck Gomez and John Appel, PA. Two guys that I've known for a really long time. They both love orthopedics, and we're going to be talking about common orthopedic emergencies in kids. We'll see you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.